Good evening friends, welcome to my channel Critical Care Basics, and this is the third lecture on ABG. In the first lecture we saw about the technique of taking a sample. In the second lecture we talked about the acid-base interpretation in ABG, and in this third lecture we are going to talk about oxygenation parameters in ABG, the commonly used ones. So let's begin. Let's understand the two terms first. What is hypoxia and hypoxemia? Hypoxia is defined as a condition where oxygen supply is inadequate either to the body as a whole, general hypoxia, or to a specific region, which is called as tissue hypoxia. So this is the inadequate oxygen supply or the effect of inadequate oxygen supply at the tissue level. It can be due to reduced oxygen delivery, increased oxygen consumption, or inability to utilize oxygen. While hypoxemia is defined as an arterial oxygen tension less than 60 or PaO2 less than 60. So this is very easily measurable. Hypoxemia does not necessarily always indicate tissue hypoxia. Hypoxia, while hypoxemia remains the topmost cause of hypoxia, there could be other causes. The four categories of causes of hypoxia are: number one, and the foremost one is hypoxemia, that is reduced oxygen partial pressure in blood, then anemia, then dyshemoglobinemia like carboxyhemoglobinemia or methemoglobinemia. We'll shortly discuss these two later in this lecture. And lastly, histotoxic hypoxia, for example in cyanide poisoning, when there is oxygen in the blood but the oxygen cannot be utilized due to the improper phosphorylation. Commonly used measures of oxygen in ABG. First is oxygen dissolved in blood. So majority of oxygen in blood is transported through the RBCs, through the hemoglobin, and each molecule of hemoglobin has a capacity to accept 4 molecules of oxygen. So 98% of oxygen is bound to hemoglobin, but there is some amount of oxygen which is dissolved in blood, which is less than 2%, so not really that important, but we give a lot of importance to this value nevertheless. This is called as PaO2, partial pressure of oxygen in arterial blood. Small a stands for arterial blood, while large A, as we'll see later on, stands for alveolus. So this is partial pressure of oxygen in arterial blood. This is measured in ABG. And oxygen bound to hemoglobin, we can measure it in a non-invasive way in form of SpO2. SpO2 is a non-invasive estimate of the percent of oxyhemoglobin in the capillary bed that uses co-oximetry and a pulse oximeter. While SaO2, small a02, is a direct measurement of percent of oxyhemoglobin, means that amount or percentage of hemoglobin which is saturated with oxygen. So that is direct measurement of oxyhemoglobin is SaO2. Now, AA gradient, this is widely used to see in an ABG whether the pathology is within the lungs or it is just hypoventilation. So, AA gradient is a non-specific indicator of integrity of alveolo-capillary membrane. Thus, any pathology of alveolo-capillary unit widens the gradient. What is AA gradient? The large A or big A, PaO2, stands for partial pressure of oxygen in the alveolus, while P small a02 means the partial pressure of oxygen in blood. As you know, in the alveoli, the carbon dioxide goes from blood to the alveoli and the oxygen comes from alveolus to the blood. So any problem in this transfer of oxygen from the alveolus to the blood will increase the AA gradient or will widen the gap. So in an ABG, if we see the AaO2 has increased, then probably there is some problem in the lungs, as we'll see this. Now, PaO2, P small aO2 is directly calculated in the ABG, directly measured in the ABG. But P large aO2 is partial pressure of oxygen in alveolus, has to be calculated. So it is calculated by alveolar gas equation. Alveolar gas equation is P large aO2 is equal to FiO2. FiO2 means fraction of oxygen in inspired air. For example, in room temperature, in room air, the FiO2 is 0.21 or 21%. Then multiplied by Pb means atmospheric pressure minus PH2O, pressure of water in alveolus, minus P small a CO2, that is partial pressure of carbon dioxide in arterial blood, divided by respiratory quotient. So you would feel that this is a very complicated equation, but this can be largely simplified, because if the ABG is being done at room air, then the FiO2 is 0.21. Partial pressure of barometric pressure, unless we are at very high altitude, is usually at sea level is 760, and the partial pressure of water in alveoli is usually 47. Lastly, respiratory quotient is usually 0.8. So we can simplify this equation. P large aO2 is equal to FiO2 divided by Pb minus PH2O minus PaCO2 divided by respiratory quotient. So this is FiO2 is 0.21 in room air, atmospheric pressure is 760, partial pressure of water in alveolus is 47, minus PaCO2 divided by 0.8. This is the respiratory quotient. So the equation is simplified as follows: P large aO2 is equal to 150 minus PaCO2 divided by 0.8. So on room air at sea level. So now we can easily calculate the partial pressure of oxygen in the alveolus. Now I have shown you this calculation so that you know how it is calculated, but most of the ABG reports directly reveal this PA gradient. So this is A minus A gradient is 32.2 in this ABG. So it is directly written on the ABG, so you need not do these calculations, but we are discussing this calculation because you must know how the values came. What is the use of this AA gradient? If this AA gradient is normal, then either the patient is at very high altitude or hypoventilation is the cause, means the lungs are normal. The problem of hypoxemia is due to hypoventilation. While if the gradient is widened or raised, then there could be three possibilities. One is ventilation perfusion mismatch, or diffusion limitation, means the oxygen is not able to pass from alveoli through the capillary basement membrane into the artery, and lastly there could be a shunt, either intracardiac shunt or shunt somewhere else. So normal AA gradient is calculated by the formula H divided by 4 plus 4. So whenever we see ABG, we come to know the AA gradient. In that patient, always calculate what is the expected normal gradient. So this is the formula for expected normal gradient, H divided by 4 plus 4. This is the formula for the patient who is breathing room air. But as we all know, in alveolar gas equation, we have FiO2. So if the FiO2 changes, that is if the patient is breathing oxygen, then the formula of normal expected AA gradient becomes H divided by 4 plus 4 plus 50 multiplied by FiO2 minus 0.21. So we'll see the examples. For example, a 46-year-old healthy patient comes with a drug overdose and has a respiratory rate of 8. So as you can see in this example, this is a healthy patient, 46-year-old, and he has taken some drug and the respiratory rate is very low. So you expect that this patient has hypoventilation. His ABG on room air is pH 7.31. We have seen the acid-base interpretation. This is acidosis. PCO2 has raised, so this is respiratory acidosis. This also goes in favor of hypoventilation. But in present lecture, we are going to discuss not about the acid-base abnormalities, but about the oxygenation. So let's focus on the AA gradient. How will you calculate AA gradient? AA gradient is P large AO2 minus P small AO2. P small AO2 we already know is 65. We will calculate the P large AO2 by alveolar simplified alveolar gas equation, that is 150 minus PaCO2 divided by 0.8. So that comes to 16, right? So his AA gradient is 16. Let's calculate his expected normal AA gradient. 46 is his age divided by 4 plus 4. So 11.4 plus 4, that comes to 15.5. So expected AA gradient is 15.5. While his calculated AA gradient is 16, so these match. Therefore, the lungs are normal. The hypoxemia is solely due to hypoventilation. So this is how this AA gradient help. Let's see another example. A 56-year-old patient with pneumonia. Now we already know that this patient has pneumonia, so there could be problems with the lungs. Who is mechanically ventilated, is developing worsening hypoxemia. So he is already on mechanical ventilation and his oxygen saturation has worsened. His FiO2 on ventilator is increased to 80%. Now because his FiO2 is 80% and not 0.21, we will have to change the alveolar gas equation to this FiO2. His ABG is given below, pH 7.31, PCO2 55. Again, this suggests that the patient has respiratory acidosis. His SpO2 is 88%, PO2 is 65. So assuming that the patient is at normal atmospheric pressure and water pressure in the alveolus is normal and respiratory quotient are normal. So the calculated large A small a gradient or oxygen gradient is equal to here, instead of 150 minus PCO2 divided by respiratory quotient, we will have to calculate, put in the FiO2 value. So FiO2 into atmospheric pressure minus pressure of water minus PCO2 divided by respiratory quotient. So this is 0.8 divided by 760 minus 47 minus the PCO2 is 55 divided by 0.8. And this is the large A, PA large AO2, that is partial pressure of oxygen in alveolus, minus this 65 is the PaO2. Small AO2. So that comes to AA gradient comes to 436. It is highly raised. Now what is the expected gradient in this patient? Is the 56-year-old patient. So age divided by 4 plus 4. Then this patient is on a FiO2 of 80%. So plus 50 into FiO2 minus 0.21, that is 0.8 minus 0.21. So that comes to 48. So expected AA gradient is 48, while actual AA gradient is 438. That means the AA gradient is widened. So as we know, this patient already has pneumonia. So in this patient, the increased AA gradient is due to his pneumonia creating a physical barrier or a diffusion defect within the alveoli, diffusion defect limiting the transfer of oxygen from the alveolus to the blood. So this is how the AA gradient helps in narrowing the diagnosis. Another example. So a 56-year-old male, again known patient of coronary artery disease, hypertension, he is also a chronic smoker, presents with a productive cough and dyspnea for 3 days. On examination, his respiratory rate is 28, SpO2 is 81% on room air. Now ABG, pH 7.31 and PaCO2 is 60, again respiratory acidosis, while PaO2 is 57. Let's check the AA gradient. Because this patient has an FiO2 of 0.21%, he is breathing on room air. So the simplified alveolar gas equation will be P big AO2 will be 150 minus 60 divided by 0.8, that is 75. And the P small AO2 is given to 57. So 75 minus 57 is 18. And let's calculate his expected normal AA gradient. That is age divided by 4 plus 4. So 56 divided by 4 plus 4, that comes to 18. So his expected AA gradient and the actual AA gradient is same. That means this patient has hypoventilation, the lungs normal. Therefore, cause of his hypoxemia is solely hypoventilation. Otherwise, you will be tempted, seeing this example, you will be probably tempted he has pneumonia and you will be tempted to give antibiotics. But after seeing this, given that he is a chronic smoker and his respiratory acidosis, so it is amply clear that he has only COPD exacerbation and not heart failure or pneumonia. So that this helps in preventing unnecessary use of antibiotics or other measures. The second thing that we see in ABG is the PaO2 FiO2 ratio. This is usually seen in patients who are on mechanical ventilation. PaO2 FiO2 ratio is another common measure of oxygenation, most often employed in ventilated patient. This is mostly used in the diagnosis of ARDS. The Berlin criteria for defining ARDS includes calculating the PaO2 FiO2 ratio, or it is sometimes simply called as PF ratio. What is PaO2 FiO2 ratio? PaO2 FiO2 ratio is calculated by dividing the arterial partial pressure of oxygen, P small a02, divided by FiO2, that is the fraction of oxygen in inspired air. For example, if a patient has a PaO2 of 60 and the FiO2 is 0.5, that is 50%, then his ratio will be 60 divided by 0.5, that is 120. Right? So very simple. It comes handy in patients with ARDS. But ARDS is not diagnosed by PF ratio alone. So let's have a look at the Berlin definition of ARDS. This definition necessitates 4 criteria. Number 1, respiratory symptoms must have begun within 1 week of known clinical insult. Patient must have new or worsening symptoms. So patient must have deteriorated in last 1 week. Number 2, bilateral opacities must be present on chest x-rays. So bilateral opacities on chest x-rays or CT chest, these opacities must not be fully explained by pleural effusion, lobar collapse, lung collapse or pulmonary nodules. So if the patient has bilateral pleural effusion, this will not come under the bilateral opacities required for ARDS. So there should not be bilateral pleural effusion or lung collapse or pulmonary nodules. So there should be bilateral opacities, means bilateral infiltrates. And the patient respiratory failure must not be fully explained by cardiac failure. So a patient with cardiac failure will have a backswing or bilateral pulmonary edema. So that is not included in the ARDS. So you should rule out fluid overload and heart failure. This can be done by ruling out pulmonary arterial hypertension in echo. And in addition to all these criteria, then you see the PF ratio. If the PF ratio is less, then the patient, in addition to all this, then the patient has ARDS. So in ARDS, these are the different categories of ARDS: mild, moderate and severe, depending upon the PaO2 FiO2 ratio. What is a normal PaO2 FiO2 ratio? Is between 300 to 500. For example, in a normal person, the PaO2 is 80 and the FiO2 is 21%, so 0.21%. So ratio is about 380. So normal ratio is about 300 to 500. But in ARDS, if the ratio is more than 200 but less than 300, that is called as mild ARDS. Initially, it used to be called as acute lung injury, but now the terminology has changed to mild ARDS. PF ratio 100 to 200 is moderate ARDS, and PF ratio less than 100 is severe ARDS, in addition to all these criteria that we saw in the Berlin definition. So this is the use of PF ratio in ABG. Another parameter that is sometimes seen is SVO2 or SCVO2, that is called mixed and central venous oxygen saturation. So as we all know, the deoxygenated blood or the impure blood comes from the superior and inferior vena cava to the right atrium. From right atrium it goes to right ventricle, and from right ventricle it goes to pulmonary artery. So if we have a catheter in pulmonary artery, for example we have a Schwann-Ganz catheter, and we take a sample from the Schwanzget catheter and run it in the ABG machine, then it will show what is called as SVO2, mixed venous oxygen saturation, SVO2. Or if we do not have a pulmonary artery catheter in situ, but we have a central line. So central line does not reach here, so that will not be the perfect measurement for a mixed venous saturation, but it will be a surrogate. So central line is a common situation in ICU, while pulmonary artery catheter is largely outdated. So nobody uses pulmonary artery catheter for routine ICU patients. So instead of SVO2, we can measure SCVO2. We can take a sample from the central line and run it in the ABG. This is a venous sample, and SVCO2 measurements obtained from the internal jugular or subclavian catheters are often used as a surrogate for SVCO2. What does this show? SVO2 and SVCO2 reflect the degree of oxygen extraction by the tissues. So if the tissues are severely hypoxic, then they will extract more and more oxygen from the blood, and the SVO2 will be lesser. So normal SVO2 is 60 to 80%, while normal SCVO2 is more than 70%. So in sepsis guideline, in early goal directed therapy, after all the parameters have been checked, if the SCVO2 was less than 70% or 60%, this was used as a criteria to start dobutamine, right? So they are lowering patients with increased oxygen extraction due to high metabolic states or decreased cardiac outputs. So whenever the cardiac output is less or high metabolic states, then more oxygen is extracted. So they are usually decreased in these patients. They are usually also decreased in sepsis. Sometimes they are increased in sepsis. The most of the time they are decreased in sepsis. Now, after seeing SVCO2, this is another index called oxygen content. As we all know, oxygen in blood is mostly transported with the help of hemoglobin. So saturation, SaO2 is 98% of oxygen is saturated, is transported via hemoglobin, but less than 2% is transported dissolved in blood, that is measured by PaO2. So if we have to calculate the total amount of oxygen in blood, what is called as oxygen content, we will have to get the hemoglobin as well as SaO2 and PO2. So SaO2 and PO2 we measure in the ABG. So the formula for oxygen content is 1.34 into hemoglobin into SO2. Why 1.34? This is the capacity of hemoglobin to attach or combine with 1.34 grams of oxygen. So 1.34 into hemoglobin into SO2 plus 0.0031 into PaCO2. So this is sometimes used to determine the shunt fraction and oxygen delivery. If the patient say has anemia, since PO2 is dependent on dissolved oxygen, the PO2 will be normal because PO2 is the oxygen that is dissolved in the blood. So if the patient has severe anemia, suppose the hemoglobin is 5 grams, his PO2 will be normal, but oxygen content will be less, right? So this is useful in patients who have anemia. So in anemia, the oxygen content will be less, while PO2 would be normal. Oxygenation index, this is in addition to PF ratio. The PF ratio is multiplied by mean airway pressure. Most commonly used in neonates with persistent pulmonary hypertension of newborn, PPHN. So this is not used in adults, but used in persistent pulmonary hypertension of newborn. Oxygen index is used to determine the severity of hypoxemia and to guide the timing of interventions such as inhaled nitric oxide. It is calculated by mean airway pressure into FiO2 divided by PO2 into 100. So if the oxygen index is more than 25, it indicates severe hypoxemic respiratory failure. So this is just to complete the list. This is not used in adults. So I have never calculated this oxygenation index. Few slides, 1 or 2 slides about abnormal hemoglobins. So some ABG machines also detect carboxyhemoglobin and methemoglobin. So what is carboxyhemoglobin? Carbon monoxide is a gas Sometimes it is released also in cars, and some burning of some gases created in some factories. So what happens? It has a very high affinity for hemoglobin. Its affinity for hemoglobin is 240 times that of oxygen. So if there is carbon monoxide, it immediately gets attached to the hemoglobin, causing what is called as carboxyhemoglobin. And carboxyhemoglobin does not, what happens normally, whenever the blood is in the lungs, the oxygen attaches to the hemoglobin, and whenever we go to the tissues, the oxygen detaches. This is as you know from the oxygen dissociation curve. While this carbon monoxide has such a high affinity for hemoglobin, it will not detach, so there will be hypoxia. What is important is the oxygen dissociation curve will shift to left, and importantly the SpO2 is normal. So if you see the SpO2, patient is severely hypoxemic. The SpO2 normal, but PaO2 is low. ABG will detect carboxy. If the ABG has the faculty of determining the hemoglobin, some ABGs have those electrode, then they can detect the carboxyhemoglobin. Apart from not detaching from the hemoglobin, it also causes problem in the phosphorylation or the cytochrome system. So both ways it hampers, it also causes tissue hypoxia. So this is called as oxygen saturation gap. This happens in carbon monoxide poisoning. What is this? Carbon monoxide tricks the pulse oximeter into reporting high SaO2. So if we see a patient of carbon monoxide, suppose a patient there was some problem in a car, and it's somehow it produced carbon monoxide. This has happened, and it is a gas which you cannot detect because it has no smell, and the patient suddenly becomes unconscious. Such an unconscious patient is brought to the emergency department, and you see the SpO2 is normal, but regardless of what saturation actually is. So oxygen saturation gap refers to a patient with carbon monoxide poisoning and hypoxemia. This produces a gap between the pulse oximetry, which is close to 100%, compared to PO2, which may be low. So PO2 is low, the oxygen amount dissolved in the blood is low. That means the patient has not got oxygen, but the saturation, it is showing 100%. This may be helpful if you stumble over it, but shouldn't be used as intentionally used as a criteria for CO poisoning. So if you see such ABGs, you may interpret that probably this is a venous ABG. So just have a careful look. If the SO2 is normal, SaO2 is normal, but the PO2 is low, in such scenario, there could be carbon monoxide poisoning. Another abnormal hemoglobin is methemoglobin. This could be genetic, or there could be dietary problems, some oxidizing chemical problems, or sometimes idiopathic. Methemoglobin is a hemoglobin that has been oxidized. So normally in hemoglobin, the ion is present in the ferrous form, that is 2+, and it gets converted to 3+ in methemoglobin. So Fe2+ allows the binding of oxygen, while Fe3+ does not allow the binding of oxygen. So it does not have affinity for oxygen. The hemoglobin normally should have affinity for oxygen. Only then the oxygen will get into hemoglobin and it will get saturated. So does not allow the binding of oxygen. RBCs carry oxygen in high concentration, therefore continuously exposed to free radicals. So this is how the oxygen dissociation curve is shifted to the left. Ferric heme causes increased O2 affinity of ferrous hemes, resulting in left-sided dissociation of oxygen dissociation curve. So this is also, methemoglobin is also detected by machines, ABG machines, which have these electrodes in them. A lot. So this was the third lecture on the ABG. We have covered the technicalities of ABG, taking sample, then we have covered the acid-base interpretation, and these are the oxygen parameters that we see in the ABG. I hope you are liking this lecture. If you are liking, please like, subscribe and share. Thanks a lot. Bye bye.